Hope y'all are doing good. Props to showing up after the exam.
I know. We're
Good
still
for y'all.
dead in the brain too. Don't worry, we feel you.
Yeah. So I'm just here for moral support. I'm just gonna drop a few tips for you guys, but obviously Lindsey was a scribe for many years, so she is going to be the go-to for this. She's definitely the one to ask questions regarding these things.
Oh, sorry. Okay, the slides are posted on Dogmom for you to peruse and annotate, take notes. So the goal of this session is to kind of give you some tips and tricks along the way. I know you guys have been through some small groups now, so you kind of have an idea what's going on, but if you're like us, we had a lot of questions surrounding the expectation of SOAP assessments, of OSCE, OSEX, and everything like that, what you can do, what you cannot do, how to best utilize your time, how to do things. And so my goal is to tell you what I did, what I found helpful, give you some tips. So hopefully that you can take this back to doing your small groups and doing your assessments so that it streamlines it for you, because we all know that there is an expectation you kind of learn some of this on your own, which is hard, because when I was a scribe and when I was taught how to do an HPI, there is a very steep learning curve in how to do this. And I think it's funny how little time we get to get the hang of this here. So thanks for coming. This is being recorded and we will post it later. So I'm not looking at the chat right now. But you guys can post questions in there. I do have a special place for Q&A. So here we go. Okay, so step one, you guys hear me say, set yourself up for success all the time. The first place to do this is your scratch sheet of paper. So what I do with my scratch sheet of paper, I don't know why I fold it in half and do it horizontal. It's just, it's nice to me. It makes me feel happy inside. But this is how I set up my scratch sheet every single time I do one of these small groups, every single time I go into a SOAP assessment, every single time I go into an OSCE. And the way I have it set up here, and you don't have to do it exactly like this. This is just how I did it, how I found it helpful. You can incorporate this into what you're already doing, or if you're not doing something, you can use this and see how it works. This also helps you write your SOAP note. So you go through, it has every single thing that is expected of you. And you also get the hang of this little template. And so for example, down here, allergies, past medical history, meds, all of this stuff, I always forgot that when I was talking to my patient. And so the fact that I wrote this out on my template makes sure that you're never missing it. So until you can get to the point where you can do this off book, essentially, I would write it down, because you will forget stuff. And you guys have probably already noticed that this isn't as intuitive as you think it's going to be. So CC, chief complaint at the top, this first part up here where it says CC, this is where I put everything about the chief complaint. So OPQRST, everything about my chief complaint goes there. My plus and minus signs, this is where I put anything that they either confirm or deny. And so I'm not just writing a stream of consciousness when the patient is talking, I'm actually putting it in its place. So if the chief complaint is chest pain and we're talking about chest pain and they start talking about, oh, I also have shortness of breath, I'll put that under positive. Then if they say, but I don't have this, I'll put it under negative. And I keep going back and forth so that I know exactly what I'm looking at. So that's what I do. And then allergies, med, all of that stuff, that's pretty, I don't have to describe that for you, but remember allergies, if you don't put allergies in there, you don't get the point. Like that's a huge, huge thing that they harp on. If you don't put in the allergies, you don't get that point. So make sure that you write it at the top so you always know to ask. Past medical history, whenever I ask the patient this, I always say, do you have any diagnosed past medical history? Because then they'll just start talking about random things. And they also, I don't know if you've noticed this, but they'll talk about, especially the standardized patients. I don't know if they're prompted to do this when you ask about past medical history, but they'll talk about a sickness 2 weeks ago, or they'll talk about last month this happened to me. But I don't put that as past medical history, because past medical history is really hypertension, diabetes, COPD, that kind of thing. But I use whatever they say and I put it in the appropriate place. So if they talk about 2 weeks ago, I had cold-like symptoms, I'm going to put that back up in my HPI. It's not going to go in my history, because that's pertinent to what's happening right here, right now. Past medical history is anything that affects the patient's bodily metabolism on a day-to-day basis. So again, hypertension, diabetes, COPD, that kind of thing. That's what I mean by past medical history. Medications, how I ask the patient this: do you take any medications on a daily basis? Because they'll also tell you, I took Tylenol for this, I took Imodium for this, I took cough medicine for this. That's symptomatic relief, which goes back up in the HPI. When I'm talking about meds, I'm talking about lisinopril. Do you take metformin? Do you take insulin? Those kinds of things. That's what I put in medications. So you always want to get the dose. You always want to ask them if they're compliant. So the way I ask that is, do you take it every single day? So if they, sometimes they say no, sometimes they say yes. So it's compliant versus non-compliant. So you do need to specify that. That's something that they will expect of you: compliant versus non-compliant. And if they are not compliant, this wasn't something they stressed in term 4. They are definitely stressing it in term 5. You need to figure out why they're not compliant, because there are a lot of reasons. And a big reason is, oh, I lost my insurance and I can't pay for it. Or maybe I just can't afford it, not insurance related. Or maybe I don't think they're working for me, because that can be a really big indicator. It's a really good talking point. And if you don't get it, it might be like a point loss or something like that. But you want to make sure you are teasing out the reason why somebody is non-compliant. Family history, mom, dad, aunts, uncles, like really immediate family, just put whatever you need there. I always ask surgical history now I put SHX because that's what I was taught as being surgical history. In your handbook, it calls that social history. So just be aware that that's what they call it. Or that's the abbreviation that they use. We're going to go over abbreviations later. But surgical history, and then social history, you always ask about alcohol, tobacco, and illicit drugs. Those are the 3 things that you need to tease out. And I always do it in that order. I have a formula in my head to make sure that I never miss anything. So I'll say, do you consume alcohol? And then I'll ask, if yes, I'm going to ask how much, how often. Do you smoke tobacco? If yes, how much, how often? Do you use any illicit drugs? And make sure that you specify. This sounds silly, but I also say, do you use any illicit drugs? For example, and I'll say marijuana, cocaine, heroin, so that the SP or patient knows what you're talking about, because one person's illicit drug might not be another person's illicit drug. So make sure that you are being very specific when asking. And then lifestyle is diet, exercise, occupation. Yes, you will get a lot of information from the patient when you ask these 3 things, and you'll get a lot of pertinent positives and negatives if you ask these 3 things. Sometimes they'll tell you when you ask about HPI stuff, sometimes they won't, but always get in the habit of asking it. That's something that I always forgot to ask at the beginning when we first started these, but they are very important. And then of course, vital signs, PE, plan and assessment. But this is how I set it up. And this allows me to, number 1, quickly write my SOAP note when the time comes, but it also makes sure I get everything that is expected of me, and I don't forget anything. And I'm like, oh crap, I should have asked this. So that's how I set it up. Again, go for it.
I'll just tell them how I do it, because we actually do it quite similarly. I actually fold my paper like that too. I find it easier when you're writing in your hand like that, and you could just flip it over and use the inside like a booklet too if you need more information. But that's a good way to do it. It also fits in your pocket too of your scrubs. So I do very similarly to this. So first off, chief complaint is in the patient's words, right? I have shooting pain down my leg, all right? And when they start talking in the HPI, you want this to be in the patient's words, right? You don't want to say neuropathic pain. The patient is feeling neuropathic pain, right? You want to say the patient when ambulate or when walking, the patient feels shooting pains down the right leg, right? So the whole HPI should kind of be in the patient's words. Now, I don't do the plus minus thing. If y'all are familiar with the OPQRST, that's how I started it. So you could write this down or look it up. It's onset, provocation, meaning like what were you doing when it happened? Quality, you could ask like, is it a sharp pain, or is it? And you also want to do a scale like 10 being the worst pain ever. What is it rated? The R is for radiation, like the pain in your shoulder, does it radiate anywhere down your arm or down your leg? Severity, you can ask that as well. That could qualify as the 0 out of 10. And then time, like how long has it lasted? Now, I used to use that, but what I've found is a lot of times it doesn't fit this normal rubric sort of, or this normal OPQRST. So now when I walk in, it's almost like if my mom came to me and she was like, I'm having back pain. I'm like, well, when did it start? Like the more you do, the better you get at just asking questions. Like if it was your friend and you wanted information on it, it's like, well, when did it start? What were you doing? Like, where is it exactly? Like, does it move anywhere? Like you get better with this. And so what I do instead of doing the plus minus, I just make little tick marks. I'm like, it started yesterday. And the next tick mark I put, they were gardening. And the next tick mark, it said, it's worse in the morning. It gets better with rest, and that way, when I have 10 or so bullet points, when I go to write my HPI, I literally just write out the bullet points. Pain started 2 days ago. Patient was gardening. It seems to be worse in the morning. It's a 10. It's a 6 out of 10. But the main thing about that is if you get that information, you also need to get the pertinent negatives. Okay, so when you start out where Lindsey after lifestyles, they also put ROS review of systems. So technically you can ask it down there. You could say, I want to ask some basic questions. Do you have any chest pain? Do you have any shortness of breath? Any vision changes, headaches, diarrhea, stuff like that. But what they actually are going to end up wanting you to do is putting those pertinent negatives at the end of the HPI. So so after you say, okay, the patient, it's worse in the morning, it gets better with rest, patient took Tylenol, 300 milligrams 3 times a day. You could then after that in the HPI section, patient denies chest pain, shortness of breath, nausea, vomiting, diarrhea, change in vision, anything like that. And then you could move on. Lindsey made a good point about allergies. You always have to ask about allergies. That's easy points. People forget it. I've forgotten it. You definitely have to do it. Past medical history, super important. You also want to ask if there is any recent hospitalizations too. Because like we did our mock the other day and this patient was in a manic episode for like 2 weeks and you were like, I'm pretty sure she's bipolar 1, but she's denying depression. Like, I'm like, I can't diagnose this without the cycle, right? So she's just talking about this 2 weeks of manic episode. So then I asked her, I was like, have you been hospitalized recently? She's like, yeah, 5 months ago, I was hospitalized for 5 months ago, I was hospitalized for a period of 2 months for depression. And I was like, there we go. Okay, so now we got both this 2-week phase of manic characteristics plus the depression. So now you could diagnose it. So sometimes the patients, it seems like they're only prompted to give you information if you ask the right question. Now, that being said, it is also great to ask open-ended questions, right? Can you add anything to that? So especially when you're starting out, they'll be nicer to you. And it's like, well, you say your shoulder hurts. Do you feel any other pain? Is there anything that goes along with it? Oh yeah, I also have this numbness too. Well, that's important, right? You may not necessarily ask numbness, but is there anything associated with that pain? So that's really what I wanted to add. Another thing is you should take advantage of these small groups you have now. Like some people just want to do, I don't know if y'all have done this yet where you all assign a role. Some people just want to do like the easy stuff where they sit in the back and they're like, okay, they did great. And they're just like checking stuff, like volunteer to do the physical exams, like volunteer to do the HPI. Like I promise you, like you'll get much better at it much quickly, but you need to volunteer to do it. Also, like you should write your SOAP notes. Like some people, when it was over, they would just be like, blah, blah, like, okay, I know how to do a SOAP note. But the thing is, like, there's a time constraint on that. Like, you have to be able to do these fast. So take advantage of the small groups you go to. You have to be there anyway. You might as well make the best of it. If you practice there, you'll have, there's less you'll have to do outside, right? You'll be able to do them much quicker, and you'll feel much more confident towards towards the actual graded assessment.
Yeah. Okay, so transition statements. Again, this is not as intuitive as you think it is. Interviewing a patient, talking to a patient, there's an art to it. You can't just go in and talk. So these are the exact transition statements I use to go from point to point to point. This encompasses everything you are expected to do from the facilitator rubric side. So when you walk in, hello, my name is whoever, I'm a second year medical student at SG, can I get your name and age? Okay, how would you like to be addressed? Thank you. And what brings you in today? Now, clinically, this is going to go different because anybody who has ever worked in any capacity knows patients just start talking and they talk. Some of them do. The SPs are trained to kind of follow this. And so what brings you in today? They're going to give you the chief complaint. And then you are expected to say something along the lines of, oh, I'm sorry to hear that. I'm going to do everything I can to help you. Empathy. Yes, they do great on it. Is there anything else you want to address here today? A lot of times they're going to say no, it's fine. But sometimes they'll tell you another symptom, but they're not going to expand upon anything at that time. They're just going to say, yes, I also have this and I want to talk about it. So basically they're telling you what they want to talk to you about. Clinically, this is different. I know. Just learn this for these purposes, get your points, and you'll get used to it. And then, they'll tell you sometimes like, no, it's just this. And again, empathy, this is the point where you want to set the agenda for the meeting. So I can imagine that's distressing. We're going to get a detailed history, exam, everything. And then you get the permission. Is that all right? And then, okay, tell me more about your chief complaint. Like Brady said, you want to start open-ended and you want to stay open-ended for as long as possible. So a lot of people like to go straight to closed after they talk about the chief complaint. Don't do that because you will get a lot of information from your patient if you just stay with your open-ended questions. So I'll say, okay, tell me about your chest pain. And they'll start talking. And sometimes they'll give you OPQRST in there and you don't even have to go to closed-ended to get the OPQRST. But I'll stay open-ended. I'll say, okay, is there anything else you want to tell me about this? And they'll talk again, they'll talk again. And you're going to get a lot of information from them during this time. Now, if they're leaving out bits and pieces that you want from the OPQRST or chief complaint, that's when you can start getting more closed, but only go to closed-ended after you've exhausted all open-ended questioning. You will be surprised at how much information you get without starting your closed-ended questions. So I let them talk. I'll get everything I need to get. Most of this information is going in that front top part of my template where it just says CC or HPI. If they start talking about other symptoms, I'll start putting them under my positive and negative signs. Note those positive and negative signs I actually use for my ROS. So Brady mentioned that they do have ROS. I just didn't write it in there because for me, it's easier because while they're talking, you can just put it in under a positive, negative, and go back and forth without having to put, oh, this is my ROS, thing like that. So once they've talked about their chief complaint and associated symptoms, if they give you a positive associated symptoms. So for example, if they have chest pain and they tell you about shortness of breath, you need to explore that shortness of breath. But again, we're still in open-ended question time. So if they tell you about their shortness of breath, just say, can you tell me a little bit more about your shortness of breath? Don't ask when did the shortness of breath start? Do you have this, or this? Just ask them, tell me more about your shortness of breath. Tell me more about your fever. Tell me more about your leg swelling. Again, you will be very surprised how much information they give you without asking those closed-ended questions. I keep harping on that, but honestly, it takes up so much time to just go closed-ended when you can just leave it open. Now, this first part in this little slide I have, I'm just doing my open-ended questions. Then once my patient has stopped talking, I feel like I've gotten enough information about my chief complaint, any associated symptoms that they've been telling me about. Then I transition and say, now I'm going to ask you about your history. That's when I go to the part of my template where it says allergies, past medical history, meds, and everything like that. Sometimes they will start giving you more HPI information when you're asking these questions, and I'll put that up where it is appropriate, either in the CC plus minus, but usually they'll just give you straight answers to whatever you're saying. So I'll say, again, do you have any diagnosed past medical history? Do you take any medications daily? How much, how often, family history, all of that stuff. And then I'm going to say, now I'm going to ask you a series of yes or no questions. This is your ROS. I go back to positive and negative, and I'm going to talk about this in a subsequent slide, but this is where I say, okay, do you have any fever? Do you have any chills? And I just go literally down a list in my head, just down a list. That is it. And I get my ROS, I get some more positives and negatives. Sometimes you can get more information here. If they say yes to something, you do need to explore it. So if you ask them fever under constitutional and they say yes, you got to stop and explore it. So like, when did the fever start? How high has it gotten? Did you take any medications? When did it start? So you need to explore anything that they affirm for you. Then I'm going to quickly summarize what we've discussed so far, so you can do a very abridged version of your time with that patient so far. So hit the big things. So you really just want to know that you're understanding what the patient said. So, okay, you've been having this for the last month. It got worse 2 days ago. You've had this, and this. So, 30 seconds or less, do a big abridged summary of what that patient just told you. And sometimes they'll say yes and you can move on. Sometimes they'll try to clarify something for you and you can have another kind of conversation with them. But you do need to summarize. That's something you were graded on. And then, is there anything else before we move on to the exam? At the end of this, so you'll probably think to yourself, this kind of seems repetitive. Like, do you have anything else you want to add? Do you have any questions? That's just repetitive. I get so much information out of these 2 questions before I move on to the exam, because sometimes the SP will just offer up more information that it has pertinent positives and negatives in there for you. So make sure that this is kind of like a check. Like, it's kind of like a stop point of, if I forgot anything, this makes sure that they're going to tell me something if I forgot it. So I've gotten a lot of really good information from asking these questions, and it'll also give you props in your rubric from the facilitator there. So is there anything else you want to add before we move on? And do you have any questions? And that's when you can talk to them. And if you're doing the SOAP assessment, so you're doing the group one, you'll say, okay, thank you for your time. My colleague is going to come in and do an exam in a moment. If it's you and it's your solo one, and say, okay, now based off of whatever, I'm going to perform this, and then this entails, do I have your permission to continue? So that is that transition. But these are the exact statements I use to go through my entire encounter. This encompasses everything that the rubric is expecting of you. And so when they talk about organization, when they talk about you set up the agenda, when they talk about you did summarizing and all of this stuff, this is going to give you at all of those points on the rubric. And it's also going to help you stay organized when you're talking to the patient. Brady, did you have something to say?
So yeah, I just wanted to reiterate, they don't tell you when to summarize, but like, I think I do the same as Lindsey, like right after you finish this part, like right before you do the physical. And sometimes like, that's when you kind of just regurgitate kind of what happened. Just give them a little story. This happened 2 days ago. This is what was going on. Because sometimes things get lost in translation, right? You'll think they said, I've been in pain for 6 hours, and then they'll correct you. They're like, no, the pain started, or it happened 6 hours ago, but it didn't last 6 hours. Like, sometimes little things get lost, and sometimes after they hear you say it back, they'll remember something. They're like, oh, I'm supposed to say that too. So right after you finish getting all this information is a good time to summarize it. Plus, you want to get that point in there, because as you're going to see, when you start getting to the physical exam, you're going to be running out of time. So it's one of those things you definitely want to get credit for. So it's a good time to do it.
Yeah. I'm sorry, there's stuff going on in the chat and I am not looking at it.
I got it. No worries.
Okay, thanks. Okay. So this is an example from small group of me utilizing my template to get everything I need. This looks kind of crazy. I understand that, but I kind of write haphazardly in the moment when they're talking. But you'll see how I do it though. So chief complaint, I wrote it down, HPI. I didn't know what she said. Sometimes it's hard to tell. To tell what they say. So you'll kind of see how I abbreviate just when they're talking too. So I use like a happy face and a smile and a sad face when they say made better with or made worse with, because it takes so long to write that out. So I just do a little sign that tells me this is what they're talking about. So because you also want to stay engaged with the patient, you want to look at the patient, you want to make sure you're listening to them and not paying attention to writing down what's going on, because then you'll miss things. And so even just here, I abbreviate a lot. I do a lot of just little signs and symbols to tell me what's going on with this patient. So you'll see that everything they told me that it surrounded their chief complaint is up here. And then their associated symptoms. So they said bilateral leg swelling, or I wrote the bilateral, but they said both of my legs are swollen. And then I put, okay, this is at the same time. It started in the feet, moved above the ankle. They also have fatigue. They also have cough. So I have 3 positive symptoms here, and I had to explore each of these 3 positive symptoms. And then you'll see here that I have a lot of negative symptoms. So these negative symptoms could have come from when I asked about the chief complaint, or they could have come from when I did my whole, okay, now I'm going to ask you a series of yes or no questions. And then I would just written that here. You'll see if they don't have anything, I do the symbol for nothing. I don't write it out. And then my abbreviations, yes, we're going to go over those in a minute, but I am abbreviate essentially everything. Again, I don't put ROS in here. This is one of the first ones I did in term 4. And so I was playing with how I wanted my template to be, but I don't put ROS here anymore. I just did the positive and negative signs up in my HPI so that I could go back and forth and list out everything that the patient was saying. And then, so this is all my subjective on the left side, and my objective is on the right. So vital signs, you always have to do general appearance, then any of your physical exam findings, repeat if you have them, and then differentials. This is very haphazard because again, I was still developing my template, but I put everything in there, and then you'll see my notes to myself because my group always met afterwards to debrief. And so I was like, okay, like I have to remember this, I have to remember this, I have to remember this. So I would always just like bring my, give myself notes to do. And I kept you're not supposed to keep, I didn't know this. I did not know this. Did you know this, Brady? After your small groups where you do them, you're not supposed to keep these. And I kept all of them because I would write notes and I would highlight it so that I could practice.
I just threw them away after I wrote my soap note. Yeah, I don't know.
Well,
I didn't know that we were supposed to.
Extra.
For the graded ones, yeah, for sure, you have to throw it away. But
oh yeah, the graded ones, you have to tear them up on the screen. But these are from small group, and I saved all of them so that I could write notes to myself and remember to do things that I forgot. But this is how I do it. So abbreviations, you guys know that I love abbreviations. I do them all the time because now they're second nature to me. I really don't even know that I'm doing them at this point because I've done them for so long. I highlighted or boxed ones that are common in this setting. So the vital signs, of course, they give you vital signs. And so you can use these abbreviations. Then abdomen, of course, you guys will we'll be doing the abdominal system during this. CBC, that's for your plan when you do that. CHF, COP, this is going to be your history. All of these are ones, this is straight from the stuff SG gives you. And this is also on the USMLE website. I did look it up on the website. This is straight. SG basically looked at the USMLE website and made their own little graphic from it. So straight from USMLE. Other ones, you guys know that I always use like history of, year old, those kinds of things. But I even write these down. You saw it in my template. I write these down when the patient is talking. Again, I've gotten so used to it since being a scribe, but it would, I would recommend doing that as well in your notes. So, you guys are doing small group right now. Your first SOAP assessment is what, on the 30th or something along those lines, but you have a couple weeks. And so when you're doing it in small group, practice with some of these abbreviations, because like I said, you want to make sure that you are focusing on what the patient is saying. You're focusing on the patient so that you get all of the information and you're not sitting there writing word for word what's going on in the encounter. Something that I also did when I was a scribe, I would have my own shorthand. And it wasn't shorthand that I used when I actually wrote the note and submitted it as a legal document, but it was so that I could get down big pieces of information fast and quick. But then when I actually went to write the note, I knew exactly what it was because I was the one that made this weird little abbreviation for myself. And so then I could very quickly just type it out. But in the moment when the patient was talking, I would write something that I knew I could translate later. So that's just a tip of mine when you're listening to the patient, when you're talking to the patient. If you are the person doing the history, it's a lot harder to write stuff down because you're trying to write and you're trying to talk. The first time I practiced this, I was so thrown because as a scribe, you're just typing, you're not talking to the patient and having to do two things. And so, but the biggest thing that helped me transitioning to talking and writing at the same time was using all of these abbreviations and making sure that I was writing in my template something that was short, sweet, and to the point that I could translate later really well onto my SOAP note. Now, writing your HPI. Like I said, the template that I use is very conducive to just writing a very quick SOAP note. So this is how I do it. This is how I taught my trainees to do it when I was a scribe trainer. Name, age, male, female, presented today with chief complaint. And then you fully describe the chief complaint. So this is your OPQRST. Some people write individual statements for it, but you can put it all in one statement, which is what I usually do. So I'll say, presenting today with progressively a history, a 5-month history of progressively worsening shortness of breath, made worse over the last week. So like put it all together. You don't have to do each individual statement. You can if you want, but if you can put all of the OPQRST into just one statement or two, if you have to, then that just makes it easier for you on your HPI. And then associated symptoms. So, and then patient also reports, so positive and denies. Brady made the comment, you want to make sure anything that's pertinent to the HPI goes in the HPI. So even if you're just going through your ROS, if there is a symptom that is a pertinent negative, it needs to go in the HPI. So for example, if you have a, I don't know what example to use right now. If you have abdominal pain and they deny nausea, vomiting, diarrhea, well, nausea, vomiting, diarrhea are directly related to that abdominal complaint and needs to be in your HPI because that is a pertinent negative that will rule in or rule out a differential. So it needs to go in your HPI. Anything that is associated with why they're here today, it needs to go in the HPI. But conversely, dizziness or headache, those aren't necessarily associated with an abdominal complaint. It can be, but it wouldn't be, top of my differential to be associated with it. So maybe I don't put it in my HPI, but I'll still put it in the ROS. So just be sure that in your HPI, you are putting things that are positive. That also goes for if they took Tylenol and it helped or it didn't help, or I was sick 2 weeks ago. So for example, if you come in with a numbness and tingling in your feet, and you had gastroenteritis 3 weeks ago. Well, that is really important because gastroenteritis is a precursor to Guillain-Barré syndrome. Guess what? It needs to go in your HPI. Don't put it down in your history and not put it in your HPI. Because it's very pertinent to what's going on. Even if it seems really separated and it seems like it's numbness, what does a GI infection have to do with it? It has a lot to do with it. So make sure it goes in there. So anything that is associated, but this is the template that I use every single time. I've memorized it, so now I can just easily do it. But as you're learning to to write your HPIs, this is the template I would use, because you also don't want to popcorn back and forth. That's something that my trainees, when I was a scribe, would want to do. They would popcorn back and forth, because what they would do is write a stream of consciousness in the order that the patient said it. So patients don't tell you a nice story, they're going to just talk. So it's our job to make sure we make it make sense and chronological. Chronology is one of those things that is on the rubric. You have to make sure it makes sense. So back again, my template will help you organize this so that chronology does make sense. So this is what I do for my patient.
A good thing you can do is, so like after you're in small group, after you write your SOAP note, right? So after you're timed, you write it up, time's up, go home and just read it and be like, well, okay, I probably should have moved this up here. Like you told this whole thing and you wrote at the bottom, it gets worse when they're exercising. And you're like, that's kind of important. I want to move that up in the HPI. Yeah. So like you could kind of tweak it, and then think about if somebody was telling you the story and like how you would want to hear it, right? Like it should be like almost like one of those vignettes we get on the test, right? It should kind of make sense, and the more important stuff should be at the top. So take your SOAP note and just reread it and see like, okay, that would have been good there.
But also share them with your small group. After a small group, all of us shared our stuff in the chat, and we shared our templates that we were writing on, and we shared our SOAPs, because you can learn a lot from how somebody else does it. Even me, I've been doing this for so long, but I'll read someone else's and be like, oh, that was a really good way to phrase that, or that was a really good way to do that. And so humble yourself, collaborate with everyone in small group, because the only way to get better at it is to read somebody else's and to practice and read your own and say, oh, I don't like how I did this. I could have done it this way. Because over time, I promise you that this happens. I've experienced it. I've seen it many, many times. You get used to it. And at a certain point, you can start writing these HPIs in your head without writing a single thing down when the patient talks, which when we are physicians one day, that's what we're going to have to do. So okay, this is just an example. So the one I already showed you guys. So basically I took what I wrote here and I made a short little HPI based off of this. So NR, they always just use the abbreviations for the first and last name. So I was like, okay, I'll do that. It's 55-year-old female presenting with 1 month history of shortness of breath that worsened in the last week. Again, you don't have to do complete sentences. Made worse with lying flat, has to use 3 to 4 pillows at night. It doesn't have to be this eloquent, grammatically correct, like English paper here. We're not English majors, we are science people. So short, sweet, to the point. You can leave out all the fluff and filler, get to the point. So made better with bed rest. That's not a complete sentence, but it's acceptable. Associated with productive cough. So this was just short and sweet there, using the template that I gave you here.
Can you go back real quick? I just want to make a point. Notice that Lindsey didn't put any big words like orthopnea or like, she just put worse when lying flat. You want to just speak it in what the patient has to say. Once you get down into the diagnosis, then you could say, okay, the patient has orthopnea and stuff like that. But this is all in the patient's words.
Okay, so now moving on to the physical exam, focus on the rubrics. This actually took me a really long time to figure out, quite honestly. Like the first time I was responsible for doing the physical exam in one of these small groups, I was going through the big document and I sounded like a blubbering idiot, quite honestly, because it wasn't short, it wasn't concise, and I was really confused about it. And then someone else in my group was like, let's just look at the rubrics because it tells you everything you need to do. And it was like my eyes were open, like, oh my God, that's such a good idea, because this is what they're expecting. This is what they're grading you on. Now, the rest of that document has a lot of good information for context and reference, but the rubric at the very end of the physical exam with all the pictures and stuff, this is what they're testing you on. So when you're doing the physical exam, whether in person or online, use the rubric to figure out how you're going to do it. So I would use the rubric to make my script. Don't ever call it a script in front of the facilitators. They will get very mad at you, but let's all be real. You memorize a script if you're online. In person, this shows you exactly what you need to be doing though. And then memorize the normal findings. You cannot put just within normal limits or unremarkable when you're writing your SOAP note. You have to put what you tested. So all of the physical exam documents have this at the end, right before your rubric. So look at these and practice writing them out, but also practice writing them out while your colleague is doing the physical exam, because also you cannot report something in your SOAP note that you did not do. That is fraud. You know how in big red, it always says you cannot record something in your SOAP note that your colleague or you did not do, or else you will be reported DOS because it's a professionalism concern. That's not just an SGU being cracking down on you. That is fraud. So when you are a practicing physician, if you report something in your patient chart that you did not do, it is medical fraud and it opens you up for legal action. That's why DOS is saying that. That's why the clinical department puts that. It's not just being, strict. It is, they're trying to train you to think like that, because when you get out into the real world, if you report something and it's not true, you can get in a lot of trouble for that. So make sure that when your colleague or when you are doing the physical exam, that you are kind of writing out the normal findings as it's going on. So no chest wall deformity, scars, or pulsations. Okay, so my colleague is standing there, they're inspecting the chest. Okay, so inspection, no chest wall deformities. And then when they're measuring JVP, okay, JVP is this, carotid pulse. Okay, I'm watching them take the carotid pulse. I'm watching this, I'm recording it. I'm watching this and I'm recording it. I'm watching this and I'm recording it. Just get into that habit. Yes, memorize what the normal findings are so you can easily write it down, but also get into the habit of only doing the skills and exams that are being done by either you or your colleague. That's just a very important point. And then
can I let me just add on a little something for this, because I think everybody would agree that this is the most challenging part. It's the most frustrating part. So first off, let's talk about the people that were online. So Lindsey and I did this last term. You're literally going to have to just regurgitate what this says here. So what you want to do is take a separate piece of paper, and where it says, student verbalizes to the evaluator the following. You want to say that shorthand, but so inspect the carotid bilaterally, use the stethoscope to auscultate both carotids while the patient wasn't breathing. You want to try to make it a little more concise, because otherwise you have to basically memorize every word of this. So try to make it a little more concise. That'll make it easier. But again, you're just going to have to remember all this. Now, because Lindsey and I both just took our first OSCE, this was our first one doing it in person. And I could tell you that there's not a lot of time, right? So for what you need to do when you do these is, and you'll get better with this, but you need to be able to do what's most important. If you have a patient that's complaining of sensory loss in their feet, don't start with doing reflexes in their legs, right? Check the sensation of their feet. That's going to be most important. Then you can go to the motor system. Then you can go to the reflexes. But you need to be concise on what you're doing. Don't do cranial nerves if they have sensory loss in their feet, right? So like you need to be able to, you can't just go in with like this rubric mindset. You need to go in like you're a doctor and you're like, why? Okay, I'm not worried about their eyes right now. I'm worried about why their foot, they can't feel anything in their foot. So that way you'll get most of the points you need, because a lot of people run out of time. So it's important to cover the key points. Okay, so now in regards, I agree with Lindsey. You need to basically memorize this physical exam finding, the stuff that's in blue down there. But it's very dangerous because, for instance, they will give you right before you write your SOAP, they'll give you the findings, right? And they'll give you like the JVP, the jugular venous pressure. But if you or that other person didn't do it, even though they gave you the findings, you can't write it in there. Like say if you're online and you're like, okay, I checked the jugular venous pressure, and then they give you the report and they give you jugular venous pressure. Now you could put it in your physical exam part of the SOAP note. But if you didn't verbalize it, you can't write that in there. So if you just go into the part where you're just writing the physical exam and you just write it like this, you could get in trouble. And like SGU, like Lindsey's saying, is making a big deal out of it, because it is a big deal, because like you can't do that in real life. You can't just write stuff in there that you didn't do. So like if you don't check for heaves or thrills, you can't write that in there. So I go into it with like this hybrid mindset, like stuff that's inspection, like obviously I'm inspecting, so that's all good. So I could definitely write no chest wall deformity, scars, pulsations. But then after that, I kind of like, my mindset goes to doing these things that are there in the physical exam write-up on my patient, sort of in that order, right? So like, I'm gonna check the JVP, I'm checking carotid pulses, I'm looking for heaves or thrills, looking for point of maximal impulse. That way I'm kind of like I've already memorized this. So that way I'm just kind of saying it in my head as I do it to make sure I cover all my bases, okay? Because in the beginning, they're not going to really test you on anything except your write-up. They're not testing you on patient interaction or anything. It's just the write-up. So you want to make sure you verbalize that you did all these exams. Again, it is frustrating. There's a lot of memorization, but you just have to do it. But fortunately, it's not worth a lot of points on your actual SOAP note.
Yeah. Okay, assessment and plan. This is arguably the most chill and easy part of your SOAP note. So for assessment, you just need your top 3, and the first one in your list has to be what you think the patient has, and you have to give at least 3 reasons. So put everything down there. So for example, if you think this person has CHF, why do you think they have CHS? List all the reasons. And then number 2 and 3, you can just do 2. If you can't come up with 3, that's fine. For term 4, it doesn't really matter which you choose. You just need to have a reason for it. But the good thing, they're very good at keeping these textbook. So if you have CHF, the pertinent positives and negatives are all going to point towards CHF. Clinically, it can be very sort of up in the air because no 2 patients are the same. But for your purposes right now, all of the differentials are pretty much going to be very textbook, as long as you get the information in the HPI. Sometimes you forget to ask something, you don't have a pertinent positive that would have let you decide one thing over the other, and then the facilitator tells you like, oh crap. But yeah, and then plan. Blood work is always a good idea. So, CBC, CMP, inflammation, CRP, ESR, that kind of thing, imaging, EKG, all of that stuff. So don't lose points on here, put it down here, put your best guess on everything. For it, you can pretty much, for each system, you can have a list of things that you can put down, and then, as different differentials, you might want to do certain things over or add some things very specific. But assessment and plan, hopefully it's not that crazy for you here. And then this is just an example of a SOAP note I wrote in small group. So this is what the notes I took, and then this is the SOAP that I did. Again, I shared this with my small group because we all did it and we were all sharing our own, just so that everyone could benefit from other people's, how they did it. So this is what I did. This is my complete SOAP note for one of the encounters in small group. And
And
then
if you
Hmm?
go back, let me show them something that you did right. So if you see the med section in that second part, that's how it should be in the write-up under allergies. It says meds, metformin, you put the dosage, and QD once daily, okay? BID is twice daily, TID is 3 times a day. And you also want to write if they're compliant with it, which means you have to ask them. That's very important. You'd be surprised how many of these mock scenarios they're not compliant with their medications. It's literally more in term 5, it's more often than not that they're not compliant. So that's important.
Oh, and I also want to point something out in my template that I was using. DIZZ, that's my abbreviation for dizzy. So remember how I told you guys when I'm writing stuff out, I will often just write my own little abbreviation so that I don't have to write out the entire word. That's one of the ones I always use is DIZZ for dizziness. So I would encourage you to do the same. Now, I am going to point something out in the SOAP here. Something that Brady has said to you guys twice, and I haven't really talked about, is that they are expecting you to put your HPI in the patient's words. I was not taught that when I was a scribe. We would actually get penalized if we use the patient words because this is a medical document and this is essentially for the doctor. It's not for the patient. This is clinical. Now, we all on this call know there's a difference between medical education and then clinical medicine. So in clinical medicine, I was trained by doctors, by a scribe company, to always, always, always translate a patient's words into medical jargon in an HPI. SGU says you shouldn't. So when in doubt, use what SGU tells you, because right here, right now, this is what you're doing. This is your medical education. They're training you to do, to be a doctor. And this is kind of what they're expecting of you. So when in doubt, do what SGU tells you, because honestly, once you get into the workforce, a lot of stuff is going to change in how you do stuff, because it's going to change from state, from region, from hospital, clinic, but make sure that you are doing what is expected of you right here, right now. But I've just been doing this for so long. This is how I automatically do it. And I always do well on these. So apparently they don't care that I'm using medical jargon in there, but do what SGU tells you. Do what SGU tells you, because this is your medical education right now. And then when you get to clinical medicine, when you get into the workforce, then you can just understand and be adaptive and know that sometimes it will change when you get out into the clinic. Now, just some tips. We already talked about a bunch of this stuff, but just kind of putting some things condensed for you on one slide. OSEX peeps, look at the rubric for the physical exam and find out your script. Again, don't call it a script, because if you call it a script in front of a facilitator, which I've done before, they'll be like, it's not a script. It's, you have to learn how to do it, which they're correct. But if you are having to dictate your physical exam, it's a script, because you're just, you're remembering what you do. But again, to Brady's point, and I agree with this as well, you don't have to do every single thing in a systems exam. So if you are doing respiratory exam, you might not need everything in there. So when you look at the instructions, it says focused exam. It does not say full physical exam, it says focused. So you don't have to do absolutely everything in every system. And then OSCE people, watch the physical exam videos and just copy or write out the patient instructions. I did this for the OSCE I just took. I literally just watched the videos, because they'll instruct the patient. They'll tell the patient to, move this way or do this or do this. And it's very short and concise. And so versus the document they give you, which is a little more extensive. And so I would watch those videos and literally just type out what the med student was doing and saying to practice for myself. You can write notes on your page before the time starts. So OSEX people, as soon as you show the facilitator that your pages are blank front and back, you can start writing. And so that template I showed you takes me less than 30 seconds. It doesn't take that much time, but you don't have to wait until the time starts to do it. OSCE people, You haven't experienced the flow yet, but when you're standing outside the room, you're all kind of standing in the hall in front of the doorway. You've signed into the computer to say that you know you're doing your encounter. You haven't looked at the door note yet. Time hasn't started, but you can write it out. So that's when I fold my paper in half and I do my little template there. For the group stuff, it's very similar to small group in that you will have time to go back and confer with your group and talk to the patient. So, you know, you have the however much time for the history, then you talk to your group and they're like, okay, you need to ask this, 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 and this, and then you go back and talk to the patient. This is my personal tip right here, because like I said, my small group debriefed after every single one of our small groups and we practiced together. There were not every group did that. I mean, we did that and we took the initiative to do it and we actually got very good at it because we all knew what the expectation was. My tip is to do the same. But when you are going back, just get your pertinent positives and negatives and leave it at that. You don't have to use every moment of the time given to you. If you get your pertinent positives and negatives and you know what that patient has, you don't have to go back and talk to the patient to get just extraneous information, because at that point, you're writing a novel. And it's going to take a long time to write an HPI because you just have all of this information that you've asked the patient because, oh, I'm going to have 2 minutes left. I might as well ask the patient this. My personal tip, and remember, I'm saying personal tip because this is just what I do. Take it or leave it, take it with a grain of salt. If I have all of my pertinent positives and negatives that have ruled in and ruled out what I want, I leave it at that and we just move on with the encounter. ROS, I would suggest coming up with a list so you don't have to waste time thinking about it, because you do get tongue-tied and you have knowledge blanks when you're talking to the patient and you're like, oh crap, what should I ask them? And you're doing the ROS, you're like, I don't know what to do. Just come up with a list in your head. I have ones that I always do. So HENT, you know, red or itchy eyes. Chest pain, shortness of breath is really easy for CV. Constitutional, I always put fever and chills. That's a really important one. Fever and chills should always be something you ask. MSK, do you have any muscle pains, joint pains? Rash is another good one. Dysuria, hematuria, headache, dizziness. So this is the list I always have in my head so that when I get to the ROS part and I'm asking them just for yes or no, I don't have to sit there and think about it and waste time. Now, I know that these assessments aren't worth much, but please take them seriously. Why do I think you need to take them seriously? Because you have to do it on your own at some point. And if you don't get used to writing a good SOAP, talking to the patient and getting a good history, doing the physical exam and doing the closure, you're going to have to learn it all, you know, in a day or two for your solo run. And so I would suggest taking them seriously so that you get used to it. And the studying that you're doing for the OSEX or OSCE is very minimal and you're really just solidifying points at that time. Brady, did you
like 100%, like you're in there with a mock patient, like you're going through the process. You can't really mimic that with your friends like 2 days before. Like if you're going to freeze, if you're going to lock up, if you're going to forget something, let it be when it doesn't matter, right? Because you have to be fast too. Like the time is an issue. Some people do it fast and it's still an issue. So like you need to get good at this. I just wanted to add one thing. So when you do these group patient exams and then you all write the write-up, right? So you're going to get a couple of practice ones. When it gets to the one that's graded, like whether this is the nicest thing to say, you need to put the people that are best at their position at the position, right? Some people will be better at doing certain things than others. So when it's graded, since you're all graded on it, it's important that, the people that maybe have been scribes before, like, leave the pride and egos out of it. Like if somebody's been a scribe, like let them do the HPI. Like they could get it out in like 2 minutes where it would take you like 4 or 5. So you're going to get different opportunities. Maybe the people that are a little bit weaker can go for the second one, right? Because you want to be able to, because you all are going to take notes on what the other person is asking. Like the person that does the HPI, you're going to take notes on your own, but you're all going to write a separate soap note. So use the time to be able to practice, to figure out who fits what role best. And then maybe for the next one, it'll give people time to kind of figure it out and get a little bit faster and more comfortable with it.
I agree totally with that, because my group, we knew who was best at what, and we would rotate and practice different roles in the small group. But when it came time to it, we're like, no, you're doing this, you're doing this, and you're doing this, because we want to get through it. We want to do it well. We want to do it right. So that everyone has the best chance to write a good SOAP note. So 100% agree with that. That's what my group did. And then my last point here, when in doubt, ask CPD at sg.edu. It is no joke, or it's not a secret. My God, I can't think of words. It's not a secret that sometimes facilitators are going to contradict other facilitators. It happens, and it causes a lot of confusion. If you are hearing different things from different facilitators, which I did, you're probably doing, it's a thing, reach out to the clinical skills department, because they're ultimately the ones that are saying, this is the expectation and this is what you can and cannot do. So if you and your friends are talking after small groups, like, well, my facilitator said we can do this, but mine said we can do this, make sure you're asking, make sure you're reaching out to see what the actual expectation is. We had to do that a few times to get some things cleared up, but that is all I have for you today. Do you guys have any specific questions?
Wait, we have to talk about it. Did we wash our hands first? Because I think we got points off. You always have to wash your hands.
Yes,
first.
sanitize.
You walk in and
do the physical exam.
Yeah, I do it when I walk in the room. So like the first thing I do is so I don't forget. This is one thing you need to remember, empathy, all right? There's a big difference between sympathy and empathy. Sympathy is saying, I feel sorry for you. Like, I'm sorry you're going through that. They don't want that. They want empathy. Here's the thing about empathy. The patient, the mock patient, is the one grading you on it. So what you need to do, you need to not be a robot thinking about your rubric. You need to stop. You need to look the patient in the eyes and say, I understand you're going through something difficult. We're going to do our best to help you. Okay. Like, say that 2 or 3 times, but stop what you're doing. You can't be like, we're here for you. Like, as you write stuff and you're like, okay, how long was the diarrhea? Like, it's not like that. You need to like, look at them and be like, I understand, not I'm sorry. I understand what you're going through is difficult. Some of my friends think it's great when you walk in and wash your hands, whatever, and you say, this is my name. And you ask the patient, can I get you a glass of water? Because it's a great thing to say, and it puts them at ease. And so like, it's just one of those things, like those mock patients are the one that's grading you. They want you to feel like you are personable with them. Yeah.
And a big thing too is I understand that this is affecting your job, your hobbies, because that's a huge empathy point as well. Do you understand that this is a distressing time for them? Do you understand that this is affecting their life in such a way that like they can't go to work, or they can't go swimming, and they go swimming 3 to 4 times a week, or I can't play with my grandkids, or I can't drive my car? Are you like, it seems so trivial. You are graded on it. Somebody posted a meme the other day. It was the Loki one where it was like, yes, that's great. Sorry, moving on. And I thought it was the funniest thing I've seen in like a month or something like that, because you are timed, but you are graded on empathy, but you really do have to stop and think about it. And because they're trying to develop compassionate physicians, not robots who go in and just ask questions and diagnose. So just be cognizant of that and work it into your script.
Another thing they like, if the patient says that, oh, I used to smoke like a pack of cigarettes a day for 20 years, and they're like, I cut back, you should be like, that's great. That's really good for your health. Like, make a point of saying stuff like that, like complimenting
them. Or if they never smoke.
For stuff like that. Or even if that's great, that's a good thing. Or, their diet, they're on a healthy diet. That's really good to hear that. I'm glad you're doing that, right? Like, it's kind of like almost a transition to the next question, but it also, like, the mock patients are looking for that. One thing I was going to add, I have little templates that I just made real quick with like all of the little bullet points, like to go in to make sure when I first started, I got everything. So I'll post those on the Scrubs Drive too, once we get the video up as well.
Yeah. And it doesn't have to be this big show. Like Brady was just talking about, you know, the tobacco, if you never smoked, or like one of my patients, I asked, you smoke tobacco? And they said no. And I said, have you ever smoked? And they said no. And I was like, oh, great. I love to hear that. So it doesn't have to be this overly dramatic show of empathy, but just acknowledging it in the moment. It takes 2 seconds of your time. Like, oh yeah. It's like, oh, great. I love to hear that. Good for you. So just a little tip there. But does anybody have any questions or anything they want us to hit on before we close out for the day? Okay, well, thank you guys so much for being here. We'll post the recording later today. What time is it? An hour.